Let's now begin with the fourth mini module implementing additional transmission-based precautions. Coronavirus can transmit through various ways such as through contact, droplets and air. What are the transmission-based precautions that we can take? At the end of this session, you will be able to define the concept of transmission-based precaution, explain precautions in different settings, illustrate the use of PPE in different settings, and describe the rational use of PPE. Standard precautions have to be followed all the time. All patients, all specimens, all sharps. Transmission-based precautions include, along with standard precaution, additional or second-tier precautions only when specific transmission is expected: contact, droplet, airborne. Microorganisms are transmitted by three main routes: contact transmission, droplet transmission, airborne transmission. In contact transmission, infection occurs through direct contact between the source of infection and the recipient, or indirectly through contaminated objects. In droplet transmission, infectious agents that are transmitted through respiratory droplets, large particle droplets more than 5 micrometer in size, are generated by a patient during coughing, sneezing or talking, for example coronavirus, etc. Transmission requires close contact as droplets do not remain suspended in the air and generally only travel a short distance, less than 1 meter. Here you can see a simple sketch of droplet and airborne virus and bacterial transmission. In airborne transmission occurs through the dissemination of either airborne droplet nuclei, small particle residue less than 5 micrometer in size, or evaporated droplets containing microorganisms that remain suspended in the air for long periods of time, or dust particles containing the infectious agent. Microorganisms carried in this manner can be dispersed widely by air currents and may be inhaled by a susceptible host within the same room or over a longer distance from the source patient. Precautions required in following aerosol generating procedures include endotracheal intubation, open respiratory and airway suctioning, tracheostomy care, cardiopulmonary resuscitation, sputum induction, bronchoscopy, pulmonary functional testing, manual ventilation before intubation, some dental procedures such as high-speed drilling, non-invasive ventilation or NIV such as bilevel positive airway pressure or BiPAP, continuous positive airway pressure ventilation or CPAP, high frequency oscillating ventilation or HFOV, high flow nasal oxygen or HFNO, also called high flow nasal cannula, induction of sputum, nebulization, ultrasonic or jet, and collection of oropharyngeal and nasopharyngeal swabs. Here you can see the typical chain of infection. For an infection to spread, all links must be connected. Breaking any one link will stop disease transmission. Transmission-based precautions are additional precautions taken based on the specific modes of transmission of the disease where standard precautions may not be sufficient to their own. These specific precautions control infection by interrupting the mode of transmission. Transmission-based precautions include contact and droplet precautions and airborne precautions. Precautions should be followed in addition to standard precautions for all patients with suspected or confirmed COVID-19. These precautions include wearing appropriate PPE, patient placement, patient transfer, and other IPC activities, disposable or dedicated patient care equipment. Precautions for contact transmission include continued implementation of standard precautions such as hand hygiene, keeping the patient in an isolated room. If that is not possible, cohort them, which means keep all of the similar cases in the same room, wearing gloves, gown for contact precaution, and surgical mask for droplet precaution. Frequent decontamination of the patient's room with deep cleaning after discharge. Using dedicated stethoscope and thermometer for the patient and other IPC activities. Airborne precautions are recommended only for aerosol generating procedures. Perform procedures in an adequately ventilated room, that is, natural ventilation with airflow of at least 160 liters per second per patient or in negative pressure rooms with at least 12 air changes per hour and control direction of airflow when using mechanical ventilation. For negative ventilation, duct system with exhaust fan and HEPA filter can be used. Use a particular respirator, certified N95, disposable particulate respirator. They must always perform the seal check. Limit the number of persons present in the room to the absolute minimum required for the patient's care and support. Let's now learn about the proper way to wear an N95 mask. The nose clip is located in the top panel. Perform the nose clip by gently bending at the center of the panel. Hold the respirator in one hand and pull out the bottom panel to form a cup. Turn the respirator over to expose headbands. Cup the respirator under the chin and pull the straps over the head. Locate the lower strap below the ears and the upper strap across the crown of the head. Adjust the top and bottom panels for a comfortable fit. Using both hands, mold the nose clip to the shape of the lower part of the nose. Pinching the nose piece using only one hand may result in less effective respirator performance. The seal of the respirator on the face should be fit checked prior to wearing in the work area. You can see here the do's and don'ts of using masks or respirators. Let's learn about them. You should use masks only when clinically indicated. Surgical masks should be used when handling respiratory patients, and N95 respirator or equivalent should be used when doing aerosol generating procedures. Always hold the mask by its strings. Perform hand hygiene before and after using mask. Compress the mask to ensure a seal across the nose bridge, face and cheeks. Discard surgical masks after 4 to 6 hours of use and change N95 respirator or equivalent after 8 hours. In case of shortage of supply, follow the reuse strategy. Always discard used masks in a designated bag or closed bin. Do not use a mask when clinically not indicated. Wearing masks when not indicated creates a false sense of security that can lead to neglect the other essential measures such as hand hygiene practices. Don't touch or hold the front or back part of a mask. Do not allow the tangling of mask around neck. Do not keep using a mask for longer time or days. Do not reuse masks after washing. Do not throw masks here and there after use. What precautions do we need to follow in these patient care settings? Community setting or during case findings and contact tracing. Outpatient care, collecting and handling laboratory specimens. Transfer of patients to designated facility. Case management in isolation. Let's now learn about the precautions to be taken in different settings. The precautions to be taken in community settings are applicable to all staff. IPC practices to be followed by individuals without respiratory symptoms include: avoid closed crowd spaces, maintain distance of at least 1 to 2 meters from any individual with COVID-19 respiratory symptoms, for example, coughing, sneezing, perform hand hygiene frequently using alcohol-based hand rub if hands are not visibly soiled, or soap and water when hands are visibly soiled. If coughing and sneezing, cover nose and mouth with flex elbow or paper tissue. Dispose of tissue immediately in closed bins after use and perform hand hygiene. Refrain from touching mouth and nose. Use surgical mask. Wash hand returning home. IPC practices to be followed by individuals with respiratory symptoms include: washing hands frequently, wearing surgical masks, staying at home, maintaining 1 to 2 meters of distance with each other, calling the hotlines of IEDCR or DGHS 333 16263, etc., seeking medical care such as consultation, sample collection, lab test, and treatment, washing clothes with soap and water, decontaminating the floor, table, and door locks with 0.5% sodium hypochlorite, and taking admission with an isolation center in case of respiratory distress after discussion with doctors. Let's now learn about outpatient care. Consider alternatives to face outpatient visits using telemedicine, for example, telephone consultations or cell phone video conference, to provide clinical support without direct contact with the patient. Screening, early recognition, and isolation of patient with suspected COVID-19. Emphasis on hand hygiene, respiratory hygiene, supplied masks to be used by patients with respiratory symptoms. Appropriate use of contact and droplet precautions when performing clinical examination on patients with suspected COVID-19. Prioritization of care of symptomatic patients. When symptomatic patients are required to wait, ensure they have a separate waiting area where they can sit at least 1 meter apart and provide them with masks. Educate patients and families about the early recognition of symptoms, basic precautions to be used, and which healthcare facility should refer to if any family member shows signs of COVID-19. There are certain precautions that must be followed for collecting and handling laboratory specimens from patients with suspected COVID-19. Ensure that health workers who collect specimens, including nasopharyngeal and oropharyngeal swabs, use appropriate PPE. Nasopharyngeal or nasal and throat swabs should be collected following standard precautions and airborne precautions. All personnel who transport specimens should be trained in safe handling practices and spill decontamination procedures. Specimen to be kept in specimen container, primary, and leak-proof specimen bags, that is, secondary containers, and to be transported in a cool box with 4 ice packs. Deliver all specimens by hand whenever possible. Labeling of the specimen container, that is, the primary container, and a clearly written laboratory request from containing patient's ID, patient's full name, date of birth, and clinical diagnosis of the suspected case of COVID-19. Notify the laboratory as soon as possible that the specimen is being transported. The precautions to be followed when transferring patients to designated facilities include: avoid moving and transporting patients out of their room or area unless medically necessary. If transport is required, use predetermined transport routes to minimize exposure for staff, other patients and visitors, and have the patient using a medical mask. Use designated portable X-ray equipment and or other designated diagnostic equipment. Ensure that HCWs who are transporting patients perform hand hygiene and wear appropriate PPE. Notify the area receiving the patient of any necessary precautions as early as possible before the patient's arrival. Routinely clean and disinfect surfaces which the patient is in contact. Let's now look at case management and isolation. How should patients be placed? Patients should be placed in adequately ventilated single rooms. For general ward rooms with natural ventilation, adequate ventilation is considered to be 60 liters per second per patient. For healthcare facilities without adequate natural or mechanical ventilation, the following approaches can be considered: installation of exhaust fans, installation of whirlybirds, for example, whirly kicks, wind turbines, etc., use of duct system with exhaust fan and HEPA filter. Single isolation room is recommended for patients on contact precautions. Patient notes or bedside chart should be kept outside the room. Donning and doffing should be done before entry and after exit from the room. Doors should be kept closed. What are the best practices for cohorting? When single rooms are not available, suspected COVID-19 patients should be grouped together in one ward or in one corner of a ward. All patients' beds should be placed at least 1 to 2 meters apart. A team of HCW should be dedicated to care exclusively for COVID-19 cases to reduce the risk of transmission. Restrict HCWs from entering the corona ward if they are not involved in direct care. Restrict HCWs evaluating suspected cases of COVID-19 disease. One HCW can evaluate or screen, others can maintain distance and interact, thus minimizing the need for those individuals to go to healthcare facilities for evaluation. How can we maintain spatial separation when patients are kept in isolation? If it is not possible to separate infected and non-infected patients, then a spatial separation of minimum 3 feet distance between the beds to reduce the risk of cross-contamination or infection occurring from direct or indirect contact or droplet transmission. Optimum spacing between beds is 1 to 2 meters, 3 to 6 feet. Limit the number of HCWs, family members, and visitors who are in contact with a suspected and confirmed COVID-19 patient. Maintain a record of all persons entering the patient's room, including all staff and visitors. Have signage displayed warning of the segregated area to control entry. Let's learn about the duration of contact and droplet precautions. Standard precautions should be applied at all times. Contact and droplet precautions should only be discontinued in consultation with clinicians and should take into consideration resolution of clinical signs and symptoms or the number of days since a positive test was carried out with an upper respiratory specimen by molecular assay. For symptomatic patients, These additional precautions can be discontinued 10 days after symptoms onset and at least 3 consecutive days with neither fever or nor respiratory symptoms. For asymptomatic patients, isolation can end 10 days after the initial RT-PCR test result. Although some patients have been tested positive for COVID-19 based on molecular assays several days after resolution of symptoms, it is still unknown whether these patients continue to shed the virus since only RNA viral fragments have been detected. What are the guidelines for PPE use in different settings? The first setting we'll discuss is triage. Clinical triage includes a system for assessing all patients at admission, allowing early recognition of possible 2019 and COVID infection and immediate isolation of patients with suspected COVID-19 infection in an area separate from other patients. This is known as source control. Healthcare personnel or HCPs in a triage setting are responsible for preliminary screening not involving direct contact such as observation and questioning. They should maintain physical distance of at least 1 meter, ideally build glass or plastic screens to create a barrier between themselves and the patients, wear surgical masks, and when physical distance is not feasible and yet there is no patient contact, HCP should use masks and eye protection such as goggles or face shields. Healthcare personnel who are involved with ticket dispensing or other support should also perform hand hygiene in addition. In a triage setting, there are certain protocols that should be maintained for patients with COVID-19-like symptoms. Make the patients maintain physical distance of at least 1 meter. Provide surgical masks to the patients if tolerated by them. Immediately move the patient to an isolation room or separate area away from others. If this is not feasible, ensure spatial distance of at least 1 meter from other patients. And perform hand hygiene and have the patient perform hand hygiene. Patients without symptoms suggestive of COVID-19 should always wear surgical masks and perform hand hygiene. In a laboratory setting, laboratory technologists and phlebotomists are responsible for the manipulation of respiratory samples, handling and processing of specimens from cases with suspected or confirmed COVID-19 infection that are intended for additional laboratory tests such as hematology or blood gas analysis. Note that specimen handling for molecular testing would require BSL-2 or equivalent facilities. Laboratory technologists and phlebotomists should apply standard precautions which include maintaining physical distance of at least 1 meter, wearing surgical masks, wearing eye protection such as goggles or face shield, wearing gowns and gloves, performing hand hygiene, and wearing N95 mask or face shield with surgical mask in case of aerosol generating procedures. In a consultation room setting, healthcare personnel are involved in the physical examination of patients with symptoms suggestive of COVID-19. In such a scenario, healthcare personnel should wear surgical masks, gowns, gloves, and eye protection such as goggles or face shield. They should also perform hand hygiene. Healthcare personnel involved in the physical examination of patients without symptoms suggestive of COVID-19 should wear personal protective equipment according to standard precautions and risk assessment and perform hand hygiene. In a consultation room scenario, patients with symptoms suggestive of COVID-19 should be provided with surgical masks and should be asked to perform hand hygiene and follow respiratory etiquette. In the same scenario, patients without symptoms suggestive of COVID-19 should wear surgical masks. Healthcare personnel should have such patients perform hand hygiene. In a consultation room setting, cleaners are responsible for cleaning the area after and between consultation with patients with respiratory symptoms. Therefore, cleaners need to wear surgical masks, gowns, heavy-duty gloves, eye protection such as goggles or face shields, and closed work shoes and should perform hand hygiene. Ward boys in consultation room settings who are responsible for attending to patients with symptoms suggestive of COVID-19 should wear surgical masks and gloves. In case of patient room setting, healthcare personnel who provide direct care to suspected as well as confirmed COVID-19 patients in the absence of aerosol generating procedures need to wear surgical masks, gowns, gloves, and eye protection such as goggles or face shield. They should also perform hand hygiene. Healthcare personnel who are involved in aerosol generating procedures performed on suspected or confirmed COVID-19 patients should wear N95 respirators or face shields with surgical masks, gowns, gloves, and eye protection such as goggles or face shields. They should also perform hand hygiene. Cleaners entering the room of COVID-19 patients need to wear surgical masks, gowns, heavy-duty gloves, eye protection such as goggles or face shield, and closed work shoes and perform hand hygiene. Visitors entering the room of COVID-19 patients should maintain physical distance of at least 1 meter, wear surgical masks, gowns, and gloves, and perform hand hygiene. Now that you are aware of the guidelines for the use of personal protective equipment in outpatient facilities, let's learn about the guidelines for inpatient facilities. While performing any activity that does not involve contact with COVID-19 patients in other areas of patient transit, such as in wards and corridors, and while performing administrative tasks in administrative areas, all staff, including healthcare workers as well as administrative staff, need to maintain physical distance of at least 1 meter, wear surgical masks, and perform hand hygiene. In an ambulance or transfer vehicle setting, healthcare personnel helping to transport suspected COVID-19 patients to the healthcare facility and drivers assisting with loading and unloading patients with suspected COVID-19 need to wear surgical masks, gowns, gloves, and eye protection such as goggles or face shield. They should also perform hand hygiene. Those drivers who are involved only in driving patients with suspected COVID-19 should maintain spatial distance of at least 1 meter and wear surgical masks. They should also perform hand hygiene. Note that the driver's compartment should be separated from the COVID-19 patient. Drivers who have no direct contact with patients with suspected COVID-19 but no separation between drivers and patients' compartments should wear surgical masks and perform hand hygiene. In an ambulance or transfer vehicle setting, patients with suspected COVID-19 disease who are being transported to a referral healthcare facility should wear surgical masks if tolerated and perform hand hygiene. Cleaners of ambulance or transfer vehicles who are responsible for cleaning after and between transport of patients with suspected COVID-19 disease to the referral healthcare facility need to wear surgical masks, gowns, heavy-duty gloves, eye protection in case of risk of splash from organic material or chemicals, and closed work shoes. They should also perform hand hygiene. So, what are the take-home messages from this module? Let's list them once again. Whether patients are suspected or confirmed of COVID-19, certain protocols need to be followed. Contact and droplet precautions should be followed for all patients. Airborne precautions are recommended only for aerosol generating procedures. Preferably, a patient should be in a single room. Dedicated and trained healthcare workers should take care of the patients. Healthcare workers should wear personal protective equipment. Hand hygiene should be performed regularly by everyone. Equipment should be single use and when possible, dedicated to the patient and disinfected between uses. Avoid transporting suspected or confirmed cases. If necessary, have patients wear masks. Healthcare workers should wear appropriate personal protective equipment. Routine cleaning of the environment is crucial. Limit the number of healthcare workers, visitors, and family members. All persons entering the patient's room should be recorded. Precautions should continue until the patient is asymptomatic. This brings us to the end of this module. This brings us to the end of this mini module, implementing additional transmission-based precautions. In this session, you have learned about the concept of transmission-based precaution, precautions in different settings, the use of PPE in different settings, and the rational use of PPE. You may now attempt the ungraded knowledge checks for this session.